It was 1987. It was the time when Australia still was riding on the sheep's back. John, Bob and Andrew, the three shearers. And they were driving home from their day's work in two cars. John had an alternator problem, and as you do in the bush, he pulled off to the side of the road. Andrew and Bob decided they'd give their mate a hand. So what do you do in the bush when you give your mate a hand and it's 10 o'clock at night? Of course, you turn the truck around and you shine it under the bonnet. So John, Andrew and Bob are there peering into the bonnet of John's car. And along came Charlie. Charlie had had a couple of beers after the day. It had been a big day. And as he came over the rise, he saw a set of headlights. And he thought, oh, I must be on the wrong side of the road. Bang. I hope I haven't killed that. There was a young doctor at the local hospital about half an hour away. That young doctor had just come from his intern training program at a major metropolitan hospital. He'd had 6 weeks of emergency medicine. He'd had 6 weeks of anaesthetics. He's on call in this small hospital. He gets a call from the ambulance. Doctor, we've got 3 seriously injured men on their way in. One's got a head injury. One's got multiple trauma. We don't know about his legs. The other one, he can't breathe properly. The young doctor thinks, oh my God, I've never prepared for this. What do I do? How do I manage this? So he waits and he thinks about all the things that he wished he'd known, that he should do, the things that he needs to do. The ambulance comes through, the doors open, and there's John. The young doctor checks John over and says, mate, your legs, they're gone. John looks at him. Mate, your legs are gone. John looks at him and shakes his head. Excuse me, doctor, says the nurse. John's deaf and dumb. Lights up, thanks. So that was my journey into rural medicine in 1987. And since then, I've had a long journey through rural medicine, through learning many things, to a place where now I have an organisation, a structure, a community. My presentation today is about communities of learning. The first part of this presentation is just to showcase my journey, to talk about some of the influences on my journey. I'll be then breaking to interview a younger professional who's come through and worked through the system to see her insights, because you don't just want to hear them from some crotchety old grey-haired rural doctor. And then we're going to have a conversation about some of the opportunities and challenges that I see, and these are my opinions. I've been Rural Doctors Association President now for 2 years. It's been an incredible journey in itself and some fantastic insights. We've still got a long way to go. So I grew up in a trial by fire. I had to learn everything minute by minute. That night that John came in, deaf and dumb, we amputated both his legs. I had to tell John by clipboard that his legs were no good. John was an Aboriginal man, but he was deaf and dumb. That night, I learnt the value of my mentors, the people that I work with. And it's their values, their paradigms, the things that they implicitly taught me that I've carried through for the rest of my life. And it's that very small community of learning that has, for me, enabled me to develop a passion for education and training. We have much broader communities of learning now, and I'll talk about that later. But that small community of learning was a very fragile affair. I could have broken that night. I could have not come back to rural medicine. There was no safety net but two doctors, Dr. Lou Ariotti, a trauma surgeon, and an honorary fellow of the College of Surgeons because he has been a surgeon since World War II. An incredible man who operated on people in their properties, who still had his operating table from the jungles of Borneo. Mike Muzio, a man who is med super, is now a surgeon in Ipswich. And I should not forget to mention Chester Wilson, my GP supervisor at that time. It's the information, the transformative, implicit information that I gained from that experience at that time that has carried me through the rest of my career. We need our communities of learning to very much understand that it is that very close, personal, social bond between educator and learner that creates the transformative shifts in what we do. So let's jump on 25 years. I now have a community of learning in my town. It's built up over time. We are at an incredible point in our future where we have massive investment in what we can do for people. But what I want to do, just to show you my culture, my community of learning, is let you see them and let them tell you about what they do. Let them tell you about Emerald and you will see their passion, the passion that they have and the community of learning that they are building around them. So let me show you a video.
The town of Emerald is located in the Central Highlands of Queensland. It lies approximately 270 kilometres west of the city of Rockhampton and 900 kilometres away from the Queensland capital city of Brisbane. Emerald is home to approximately 15,500 people and is recognised as a regional hub. Emerald has a diverse industry sector comprising of agriculture, horticulture, mining and tourism. Emerald has a range of primary, secondary and tertiary education facilities. Emerald has 1 hospital and 4 medical centres.
I'm Brendan Hill, I'm a GP at Emerald Medical Group. As a GP, our role is in both acute and preventative medicine, so use vaccinations as an opportunity to talk about preventative medicine in young and old, and also make sure that people are up to date with screening. We send routine reminders, and the access that people have to more subspecialised services is quite limited. It's our responsibility to then try and fill the gaps and do things within our scope of practice to make things easier for the patients and also to make sure they get appropriate healthcare without having to travel and significantly impact their lives. I do a bit of skin work as well, doing skin cancer diagnosis and simple procedures, and we're lucky here that we've got access to a visiting plastic surgeon who comes once a fortnight to do more complex things for our patients.
There are a number of different pathways available for doctors wishing to undertake GP training for practice in rural and remote Australia. There are currently 5 GP registrars undergoing GP training within Emerald Medical Group.
My name's Alison Kirby and I'm a doctor at the Emerald Hospital in Central Queensland, working as a rural generalist. My role as a rural generalist is to provide general anaesthetic services to the community of Emerald. My specialty skill is anaesthetics, so as part of that I provide the anaesthetic support for the obstetrics team and also for the elective surgical teams. When I'm not providing anaesthetic services, I work as a rural generalist, which encompasses providing all range of emergency skills, GP skills, hospitalist skills. Rural Generalists is an initiative of the Queensland Health and the Queensland Government that was put together using the Australian College of Rural and Remote Medicine. It aims to provide its trainees with a jack of all trades sort of mentality when it comes to providing generalist medicine to rural communities. The first part of the training is over 3 years, where you work exclusively in the hospitals, where you rotate through core terms including paediatrics, obstetrics and anaesthetics, as well as general medicine and general surgical. After those 3 years, you'll do an advanced skill in your chosen specialty.
Hi, my name's Jess. I'm one of the rural generalist doctors working in Emerald Hospital with advanced skill in obstetrics. We see women from sort of mid-trimester of early pregnancy through to delivery and immediate postnatal care. We provide a low-risk obstetric service here. We have set criteria for women in terms of risk factors such as BMI, so there are setting up cut-offs for that. We provide vaginal deliveries, elective and emergency caesarean sections. We currently don't offer an epidural service, but that is something that we're looking forward to introducing in the next few months, hopefully.
Emerald is a prime example of how a rural generalist team of doctors and nurses successfully deliver high-quality healthcare at a fraction of the cost of specialist care and with an improved retention of doctors.
So that video was put together by a medical student. The task for that medical student was to describe the medical community, the medical learning community in Emerald. You'll see from that video that we talked about general practice. My fellow, Brendan Hill, my colleague, is a fellow of the College of GPs. My colleagues, Alison and Jess, are products of the Queensland Rural Generalist Program. But everybody works together to produce quality outcomes for rural people. And this is my story. This is my story. I want to produce quality outcomes for rural people. And I want to do that by creating a community of learning. It's been a long journey. Then there has been many pitfalls, many opportunities. And fancy dress in the pig suit. Thank you, GPTEC. I'm going to take a break now and invite Anna Windsor to come to the stage. Anna's regional head of GP training for GP Synergy, and I hope I've got that right. But I'm going to ask Anna 3 questions. So Anna, tell me about your journey to medical education.
Where to start? Looking out into this room, Ewen wanted to meet me this morning, but getting here, I was so excited because there were so many people who've been part of that journey to why I'm here. And hi. I guess it was one of those things which was a natural progression when you're a young registrar. I was fortunate enough to be in a fantastic practice. My first ever supervisor, Grant Lewis, is here today. The practice that I worked in the Southern Highlands of New South Wales was a real nursery for education and teaching, a real community as well. Apart from Grant, my other supervisors there were all GP proceduralists that worked both doing the hospital as well as our practice. They were also very heavily involved in teaching. So my first supervisor here, Grant, there's that old adage, I think, that Andrew Morton told me when I first moved over to the west of New South Wales, that supervisors are doctors who enjoy teaching, and medical educators are teachers who happen to be doctors. And we had a bit of both in our practice there. Surrounding yourself by really inspirational people really is the way to build your own knowledge and to make yourself look a lot better than what you feel. I sit here and I feel like an imposter as far as what I've got to. But it was my first ever experience with those who I came into contact with at the start of my general practice training journey that helped shape this. My regional training provider back then was Coast City Country, and again there's some pretty inspirational people who were very formative in my career pathway. Dr. Alison Miller is the regional head for that region now with GP Synergy. And so Alison, Lukey Stanford, Saroja Gunasera, Katrina Anderson. You notice that although my supervisor, Grant Lewis, was a bloke and some of the others in my practice were blokes, I also had these amazing female mentors as well that helped me on my journey. I was very lost for many years as to where I was going with general practice, trying to have small children and decide, do I become a proceduralist or what do I do? And while I was having small kids and doing general practice, I fell into doing and really enjoying a whole lot of teaching, and so that's how I ended up on this journey. A couple of years ago, my now 11-year-old son was he went into early puberty and had a hemianopia, and it came out that he had a tumour in his hypothalamus, and that kind of nailed my decision that I didn't have the empathy to look after others as well as my own family. So my clinical work I kind of put on the back burner and did more. And there for a while was just doing mainly medical education. It got to a point where I kind of stepped away from everything, and it was during that time that there was the reshuffle of training providers. I was at that stage had moved out to the west of New South Wales and was working for Beyond Medical, but I'd stepped right back with the things going on with my son. That stepping back, I was unaware of some of the teething problems of changing from multiple regional training providers to one large training provider, which is probably good, being not understanding all of the politics involved in the change and the transition. When my son was diagnosed, another friend who had children with chronic illnesses said to me, "Anna, in 12 months' time it will become your new normal." And sure enough, it was. 12 months down the track, I could talk about it without crying and bursting into tears. And so that was the time when I thought, right, it's time to get back into doing some general practice and time to get back into doing some medical education. And it was at that stage that I contacted GP Synergy and said, look, I used to do some medical education with Coast City Country and Beyond Medical, and I really feel like I need to start doing some teaching again. And they said, yeah, that's great. We'd love to have you on board. Great. And one of the other supervisors in my practice, when I was first a GP registrar in the Southern Highlands, at that stage was doing a lot of the acting role out west, and she came out to do a bit of an induction of those who wanted to put their hand up. And when she saw me there, she just said, no, you can't just be a medical educator. You've got to put your hand up, and we need someone to run the area out the west. We're 6 months into running Western New South Wales and we still don't have a regional head. I said, oh, no, I haven't. I'm not qualified. I'm not good enough. No. She said, just put your hand up. And I said, oh, I've looked at the criteria. No. She said, you need a challenge. You've gone through a rough couple of years. You need a challenge. And she said, and let's face it, it's a Stephen Bradbury moment. I don't know. Yeah, thanks. Okay, thanks, Tess. She said, no, I didn't mean it like that. You'd be really good at it. And I said, yeah, it's okay. I get it. Yeah, Anyway, so it was a bit of a Stephen Bradbury moment, and I applied and I acknowledged kind of where my strengths and weaknesses were and what I didn't understand, and thankfully I've surrounded myself by fantastic people within the organisation that's helping plug the gaps. So that's my journey as to how I'm now kind of coordinating the western part of New South Wales.
Thank you, and thank you for sharing that very personal story as well. Can you tell me, what do you see as the opportunities and the challenges that you're facing for GP education?
Opportunities and challenge. One thing about Stephen Bradbury moment and coming into this role as a novice is that seeing things through the eyes of a novice sometimes makes you question status quo with a whole lot of things. Sometimes you question them because you just don't understand, and so that's something that I need to learn about. But sometimes when you have these light bulb moments of things you understand and you're still questioning things, it makes you really driven to change things, and that's where some of the opportunities are created. I think some of the challenges that I see in rural and regional New South Wales, I mean, I'm not going to look any bigger than that because I'm just trying to get my head around my own little turf part of the world. But one of the challenges always is the geography, but I also see one of the challenges is so many stakeholders and so many policies that sometimes are working against each other to provide fantastic services for rural and regional New South Wales, for example. I don't understand why we have a rural and general pathway. We have all these other policies in place to make sure that workforce for Western or for rural and regional Australia can be managed. So I don't understand why there is these two pathways. I think that the pathway should be that you do general practice training, and if you would like to further provide your generalist skills, that you do an extra year through either college to do that. So I don't understand why we've got rural general as well as then this FAR GP or ACRM. So I don't understand. I don't understand that. So I find that that's a real challenge, trying to go through all of that and all the different stakeholders involved in that. So that's one of the challenges. On the other hand, one of the opportunities is trying to navigate through that and help work with key stakeholders in my region to find out where are the great communities to train my registrars, where are the communities that need registrars with a certain skill set in the future, and helping to try to guide and match registrars and communities for the future.
Thank you. So you mentioned a little bit about there's so many stakeholders and it's such a complex puzzle. What do you see though as the future for GP education?
I think the future of GP education is, well, first of all, that when we went, there was a lot of us here attended the GPME conference, and we had some people from the Department of Health as well as ANU speak to us there as far as the provision of health, primary care to the rest of Australia. And fundamentally, general practice needs to survive. We cannot afford to give great health to rural and regional Australia without general practice. So the future of general practice training is to, first of all, train highly skilled, highly qualified doctors. I think that's first and foremost what we're trying to do, but also trying to create communities and inspire these highly skilled, highly qualified doctors to service the entire Australian population. So that's where I see things going.
So thank you very much, and thank you for the interview.
Thank
Thank
you.
you. So we're halfway through our presentation, and I wanted to stop and just think a little bit about what I've presented for you so far. I've spoken about my journey from the very frightening time as a young doctor with no preparation, no support, bar those of my mentors, at a time of make or break, to a situation where, through significant investment, significant support, We've been able to build a culture of learning, a community of learning in my town. We've heard from Anna about her journey, and every one of us has our own story about how we got to where we were. But you'll notice that Anna very much spoke about her mentors, her supervisors, the people who influenced her. So we've spoken a little bit about the challenges, the confusing panoply of stakeholders that exist in this environment. But as Anna has said, what we want is the outcome of better care for our communities, be they rural, be they city, be they areas of resource poor within city areas, our marginal communities, our Aboriginal and Torres Strait Islander communities, and our other communities that suffer. What I'm going to do now is just spend a few minutes talking about what I see as three of the issues or challenges. Now, they're not comprehensive. It's not comprehensive, and I may say something controversial, and please, it's not meant to offend. It's meant to stimulate conversation. To pay acknowledgement to Tim Leuenberg, I thought I'd better put a table or something up on the PowerPoint. But if you look closely at this table, we have a problem. We have too many doctors. But we have too many doctors in the wrong place doing the wrong things. We still have communities without access. We know that the further you drive from the coast, the poorer your health outcomes are. Even in city centres, there's communities where the outcomes are poor. We're training more medical students than we've ever had before. In the last 2 years, in spite of a freeze on medical schools, we've opened another 4. Macquarie University is going to train 140 full fee-paying students. We have a challenge because we have a whole bunch of junior house officers and resident medical officers who are never, ever going to achieve generalist or specialist training. We have the much touted tsunami, which has never ever reached the bush. We have a growing cohort of specialists in training who will never achieve specialist status. So we have significant challenges. And this table by the Mabel data tells us that rural specialists and rural GPs are not growing. That interest in general practice as a career continues to fall. Specialists in training are growing astronomically, but the promises of a career in specialist training are not there. So we have significant issues. How do we manage this workforce? How do we get this next generation of doctors where they need to be? I, as Rural Doctors President, have a privilege that allows me entry to speak to ministers. And I recognise Bastian, and I'm not sure if Ruth is here, but it's an incredible opportunity to see and understand how the department works, how our ministers think, and to understand how many bits of this puzzle there are. And unfortunately, the bits of the puzzle don't fit. One of the key things are the key issues for us as educators, as supervisors, as future educators and supervisors, for those registrars here, for department, for regional training organisations, is how do we set the story? How do we set an end-to-end narrative that delivers the right people to our communities? That's a body of work that we all need to be pushing in the same direction on. We need to be delivering the message to government and assisting our departments to ensure that our registrars get good training, that we set up the absolute best training that we can to deliver well-trained, resilient GPs with clinical courage who can live and work wherever they choose. We have already a number of narratives, and I'm going to jump back to my video. You'll see the term rural generalism. We soon will hear from government around the announcement of a Rural Health Commissioner, whose first order of business will be to create a National Rural Generalist Pathway or program. What does that mean? What that means to me is that we create a pipeline where we take our young people, we enthuse them, we give them a passion for rural medicine, but we support them, we mentor them, we hold their hands, I guess you could say, through thick and thin, just as my mentors did the night that John came in with no legs. But we also accept that things are changing, that what's worked up to now may not work anymore. We have to challenge our paradigms. We have to talk, and I'll talk more about service redesign. General practice in its current capacity is dying in the bush. We need different models, different ways of delivering care, but we still need resilient, confident doctors who have the training and the knowledge and skills. But it may not be the general practice that we know. So service redesign. But we also need to acknowledge that as GPs, as rural generalists, we are critical. We are absolutely critical to the future health of this country. So at some point, we have to acknowledge that they're going to have to pay us more. Leading on to my next topic, new models of care. I've, again, had an opportunity of being invited to the Primary Healthcare Advisory Group a couple of years ago now. There's an opportunity to talk about how we might do things differently. What is the essential of primary care medicine that makes it special? How can we improve access and equity for patients in city, in rural and provincial? How can we fund it? How can we make it work? How can we acknowledge that there are many other players in this space now? How can we use them as part of our team? How can we avoid headline-based cannons shooting across the bows of the Pharmacy Guild and the College of GPs? So, fundamentally, that primary healthcare advisory group was an important first step. The government, of course, and you'll see from the slides, lots of publicity, lots of visions, lots of opportunities. We've got a healthcare home trials, 200 sites. But it's just a funding model. It's taken some of the money that we earn by just, as you know now, as GPs, we have to see every patient, we have to write a care plan, we have to bill. It's taken some of that money and said, okay, you've got this group of patients here, we'll block fund them and you deliver all the care, but you can do whatever you want as long as the outcome's at the end. So that creates immense challenges for what we do now, because we have a situation where most of our GPs are contractors. They're not employees. So we have things like payroll tax, we have other challenges because sometimes the team that we would like to use isn't even there, particularly in rural practice, where you're not going to have a diabetic educator and a dietitian and everybody else just sitting in this clinic. The tyranny of distance can be a problem. But we haven't factored that in to our healthcare home models. What we fundamentally need to do in a new model of care is redesign it from the ground up. And that's thinking about transforming our workforce, having a narrative around primary care, general practice and rural generalism. A story that we can tell our registrars, a story that we can tell ourselves, that we're bigger than just the Medicare item numbers, that we have a purpose, and our purpose is to deliver better care for rural communities, through communities of learning in this case. But we have to challenge our paradigms, we have to challenge the way we think all the time. Just as I was challenged when John came into that room with his missing legs. This is a bit different, but essentially we have to challenge ourselves and say, can we do this differently? Can we do this better? Let's not stick rusted on to old traditions and old values. Only 20% of general practices are owned by a GP practice owner now. I'd love to see that go up, and I'd recognise somebody in the audience from McPhee who's only just opened their practice, and that's fantastic. But we must acknowledge we've got to do things differently, and for me in rural, that means it's not just about a healthcare home trial, it's about rebuilding the foundations, rebuilding how you fund primary care, learning from the Aboriginal medical services about how they do business, learning how we're better able to work with our team, learning about how we use telehealth and telemedicine. I'm on the primary care clinical committee for the MBS review. It's an incredibly slow process, but what an opportunity we have to reform what we do. Let's make sure everybody in this room has input into the discussions that occur out of that. For me, I'm really keen to see telehealth item numbers because the average distance a person travels to see me is 100 kilometres. I worked in a clinic on a Sunday. I sat down, saw 10 patients, asked them how far they'd travelled. Cumulatively, they'd travelled 2,000 kilometres to see me. That's an incredible distance. Maybe I could have actually done some of that stuff using telehealth and be funded for it. We need to think about how we do things differently. We build foundations. We change. Our education and training has to shift with fundamental reform. As we build these building blocks, we talk about complexity. We talk about resilience. We talk about vulnerability. We talk about clinical courage. Teaching and learning. For me, there's two types of learning in my practice. The one I found most challenging is the superficial learning that drives registrars. Oh, I've got to learn how to do a stamps. I've got to learn how to do a KFP. Oh God, the OSCE. I better go home and read my books for 3 weeks. I can't possibly see a patient. We need to challenge again our paradigms about how we educate people. Deep learning, the learning that carries us through our lifetime, does not happen out of Murtagh, I'm sorry. The deep learning does not happen from you doing an KFP or an AKT. The deep learning is from the experiences, the social learning, learning from the people you break bread with. That's where we need to focus and build our communities of learning. So I carry the person you see before you is me, is the product of many different experiences and many different challenges and opportunities. We must challenge our learners to extend themselves, and part of that challenging and extending is creating situations where they don't know what to do, where they realise that their knowledge is not effective. So, unfortunately for me, but John and Bob and Andrew, having a deaf, mute man come in with no legs was an incredible dissonance for me, because I had 6 weeks of ED training and I had no idea what to do. Let's hope we don't have to go to that extreme. But with learning to be effective rural and generalist clinicians, we really have to challenge our doctors. Just a couple of comments about these photos. The two on this side, I experienced with Dale in the audience last week, the Rural Generalist Program in Queensland. Absolute privilege to deal with young doctors who have a story that they can tell of being mentored, being supported, given opportunities to extend themselves in a pathway that will actually deliver them a product where they, as Jess and Alison could tell you in my video, they have a meaningful role in their community. Dale is, of course, also a cat whisperer. Because we had a cat come into the audience and the cat sat there and listened glued. Now, I've never seen an educator actually educate a cat, but if you need to know, Dale's just up there in the audience. I'm going to come back again to the Rural Generalist Program, because I'm not saying that the Rural Generalist Program in Queensland is the answer. But there's some key principles for teaching and learning that I think we can all learn from that. And in our immediate future, we're going to have discussions about what are the principles for a national Rural Generalist Program. And I'm sure the College of GPs and the College of Rural Medicine will have much to say about that. But just seeing these young people incredibly enthused about something that when I went to Charleville some 29 years ago, people looked at me like I was crazy. I still am, but basically these are guys that we've been able to enthuse in a career. Let's do that for general practice. Let's do that for primary care. Let's set a story and a narrative around communities of learning that will deliver that product. So it's about, at the end of the day, it's about bringing those bits of the puzzle together. And we all have a role in doing that. Our department, our ministers, our RTOs, our supervisors and our GP registrars. Just a comment about experience from other systems. I've had the great opportunity to travel to a few places around the world, not as many as Bruce Chater or Richard Murray over here, but teaching and learning in other cultures is an incredibly educational experience, I guess. The Japanese, up in the top right-hand corner, are absolutely assaulting this poor guy. As you can see, they were learning ultrasound. There were 20 of them in the room. They were all trying to stick things on his neck. That's how the Japanese learn. It was interesting for me that I was asked to give a lecture to their embryonic rural generalist program. So the Japanese have 400 islands where they have no doctors, or they have multiple specialist doctors. So I flew in a helicopter with my GP registrars 5 hours to Tokunoshima, to a 200-bed hospital for 15,000 people and 7,000 bulls. Because Tokunoshima is the capital of bullfighting in Japan. What this embryonic rural generalist program is recognised is that they need primary care in these rural communities. They've actually turned to Australia, turned to what we do here and what we do now, to understand how they build a primary care program. And again, the story that they tell, the narrative they write, is about a journey. They've started with an embryonic program and some key mentors. So I'm going to wrap up the keynote now. And I want to thank you for listening to me. I hope the theme of this conference is building blocks. What I wanted to talk to you about in this keynote is about communities of learning. What I've taken you through is how I learnt the hard way, and I survived, to where my registrars and my new fellows have developed a passion for what they do through the video. We've heard from Anna, who's spoken about her personal challenges and the great opportunities afforded medical education in this country and the future. So to summarise, the message I want you to take away from this is learning is personal. Learning is learning from people you break bread with. The deep transformative learning that you will take through your career is through incredible experiences. For regional training organisations, for the department, it's important to understand that while you may be thinking big picture, thinking numbers, thinking if I pour all these people through this funnel, a few will fall out in the bush, or if I pour through, the few will fall out over here. Actually, it's supporting your GP supervisors, your rural generalist mentors. It's creating a narrative and a story that's important. It's about filling the young people, the future doctors, with enthusiasm for a life of primary care medicine. So as medical educators, we need to think about that superficial learning which drives a lot of what the registrars do, but how we can create deep personal challenges for them that will be transformative to keep their passion alive and keep their passion going. So look, thank you very much everybody, and thank you for listening. I do hope you've enjoyed this presentation. Thank you.
Well, thank you, Ewen, on behalf of everyone here. We have got a few minutes for question time. I've got to say, Ewen's a chairperson's blessing. He keeps his own time, which is wonderful. And I'm sure that your objective to stimulate some conversation has been met, Ewen. So it's very hard to see from up here, but if we've got some questions, can you perhaps stand up so that we can see you? Not sure if we have any microphones. We do. We have a couple of microphones, I'm told. Wonderful. So if you could raise your hand, we'll get the microphone up to you.
Hi Ewan, Kate Hawkins. I'm a GP medical educator and I also work in an Aboriginal medical service in Casino in northern New South Wales. Thank you very much for your talk. I'm really interested to know how you see that the new capitation model that's going to be coming in, that's going to most likely be rolling out in Aboriginal medical services first, is going to affect that landscape, and how you see that fitting into general practice in the future.
So are you referring to the healthcare home capitation, do you mean?
Yes, so that in terms of being paid per patient as opposed to per visit, funding from Medicare.
Thank you. Can I just declare that I am on the Implementation Advisory Group and I hate what we're doing. So now that I'm no longer on the Implementation Advisory Group, look, we have to do something. We have to acknowledge that what we're doing isn't working and that government has priorities about where it spends its money. And we can wax lyrical as much as we like about the centrality of primary care, the centrality of general practice, but the business model's not surviving, so we have to do something. My concern about just picking a funding model that's going to, chop your practice into little bits is not going to fix the problem. We actually need fundamental supports for that. So fundamental supports, and what I mean by that, we need to acknowledge that the hospitals have to support us to implement a healthcare home model. So hospitals will never part with any money, okay, but we may be able to encourage them to reduce the trajectory of their spend by suggesting to them that maybe if they supported us with better communication, things like actually effective use of a meaningful My Health record, effective transfer of care back to general practice and clinical handover, then you can start to see that if the specialists didn't hang on to their patients for so long, and if hospital employed professionals didn't think that it was their patient and they handed them back to a home and they support us to deliver that care, I think that would be transformative, but I'm not convinced that just a back of a business card financial modelling is necessarily going to be successful.
Yes, just down here.
Thanks, Ewan. I'm Brett Thompson from Milton on the south coast of New South Wales. I've been a great believer in rural proceduralism and I've had a career where I've been able to do anaesthetics and obstetrics and some surgery and lots of emergency medicine. I now don't do those things because our hospitals in New South Wales don't understand how to have the delivery end of this. We're training people, we have state and federal government policies to do this. We have an incredible reservoir of enthusiastic people to do it, yet, we're in our general practice silo on one side of the street, and in the hospital they want our manpower and they want us to do stuff, but they don't understand generalism. Within their governance structures, they're incapable of seeing us as having autonomy. We're still very answerable to specialists, and whenever we have some sort of adverse event or there's a funding problem or something, we're advised by people at a different level who, frankly, we're actually competing with. And so my challenge to our profession is that for us to actually get the hospitals to actually understand general practice and deliver and be part of the contract, the social contract. And I'd like you to comment on that.
Thanks very much. Look, I agree. One of the first jobs for a rural health commissioner, and I keep referring to that, will be to try and get some sort of sense out of what's happening in different states. And you're dead right. The health department doesn't get primary care general practice, and until we, and it links back to the previous question, until we fundamentally understand that, pardon the expression everybody, but shit happens in general practice and that's where it should happen, and stuff that happens in hospitals isn't that important. And that, you know, we're the people that need to be supported. They're not going to get it. But having said that, I think there's a very clear understanding at a high level of government. So I spent yesterday in Canberra talking to politicians. I visited 3 different politicians for the same party and all had 3 different opinions about the same thing. But the narrative that I get, and I think this is through the work of ACRM and through the work of Bastion and the College of GPs and the AMA, is they're starting, at least at that level, starting to get the fact that we do need to invest in general practice. Unfortunately, they don't need to haven't parked with any money. Actually explicitly making places for doctors who train in primary care, rural generalism or general practice will be a critical part of this process. And there are levers that you can pull at various levels to make that happen. So I'm really enthusiastic about understanding what we can do in the future to make it different. State buy-in is critical to making stuff happen. If states don't buy in to making stuff happen, it will not happen. So I'm from Queensland and we're great, because we also win the football as well. But, you know, the thing that happened several years ago was a Labor politician said, this rural generalist model of care makes sense. It was telling a story. But basically, and of course there was a few reasons for that, including some random Indian people chopping people up and not, you know, having them drop dead. But, you know, at the time, it was a special time, but the state bought in. The state recognised that it actually fundamentally has a role and a primary responsibility for delivering care to rural people. So it needs to make sure that it's got well-trained doctors to do that and well-trained other health professionals. But that has transformed Queensland from having in Central West 5 GPs from Mount Isa to the border to 25 GPs and GP registrars in the last 2 years, to having rural retention rates that have gone from 0 to 80%. So we know it can be done, but it's having the political will and courage at all levels to push people to make it happen. And I'm talking about RTOs, I'm talking about departments, I'm talking about ministers. You know, we need to push these people. We need to make it very clear that the future isn't bigger, shinier hospitals. The future is general practice and primary care.